Good afternoon, everyone. Thanks so much for joining us today for our webinar on the Bridge Engagement Center. My name is Grace Higgins, and I'm the Physician Advocacy Network Senior Project Manager at Twin Cities Medical Society. We're pleased to be hosting today's event with the American Lung Association in Minnesota. Before I introduce our speaker, I just want to quickly cover some housekeeping items for today. Everyone's currently muted, and you'll remain muted for the duration of the webinar. We have allocated time at the conclusion for questions. If you have a question, feel free to type it in the chat box at any point during the webinar, and we'll read the questions aloud at the end of the webinar. Also, the slides and a video recording of the webinar will be sent out following the broadcast today, and they'll also be available on our website. If you do want to claim CME credit for attending the webinar, you must complete the evaluation that we'll send out via email at the conclusion of the event. Survey completion is mandatory if you'd like CME, but we encourage everyone to complete the survey. Next slide, please. The Physician Advocacy Network is a project of Twin Cities Medical Society, and we work to educate and engage healthcare professionals about emerging tobacco products here in Minnesota. Last year alone, the Physician Advocacy Network helped pass 8 local level policies and educated over 1,000 professionals on e-cigarettes, menthol tobacco, and other tobacco topics. We've been lucky to be involved with the American Lung Association's Leadership Academy over the past year and their work to encourage tobacco reduction among populations with mental health and substance use disorders. So that was a bit of the inspiration for this webinar today. Next slide, please. The objectives of the webinar are to describe effective strategies for meaningful patient engagement, to explain how patient engagement can help with the tobacco and growing opioid use crises, and to justify the concurrent treatment of tobacco dependence and other substance use disorders. Next slide, please. So I'd like to welcome our speaker, Dr. Smita Pakhalé. Dr. Pakhalé is a pulmonologist and assistant professor from the University of Ottawa Faculty of Medicine, serving on the American Thoracic Society's Tobacco Action Committee. Dr. Pakhalé also leads community-based research projects at the Bridge Engagement Center in downtown Ottawa, Canada, near Ottawa's largest homeless shelter. The target population at the Bridge is the most at-risk population, including those who are homeless, at risk for homelessness. The Bridge works in a true partnership with this target population, and we're very excited to have Dr. Pakhalé share the patient engagement model operationalized at the Bridge. Please join me in welcoming Dr. Pakhalé.
Thanks a lot, Grace, for that gracious introduction, and thank you for inviting and for your interest in our project. We really, really appreciate it. And when I say we, I always present with few of my Bridge participants, and I'm doing this alone because we didn't know how it's going to be with the technology and webinar. But whenever I go presenting in the city and around, even locally and nationally in Canada, people from the Bridge, people from the target population who work alongside with us, we co-present. So I'm feeling a little bit powerless, but I will try to do my best. So I have no disclosures for any of the content of the presentation and otherwise. And as Grace was mentioning, we work in the community. So we have a center, a brick and mortar center, right away from my ivory tower where I sit otherwise and do my clinic. And our center is right in the downtown where most of the most marginalized population gather around, where the largest homeless shelter is there, but even within 2-3 city blocks, there are few other facilities. They cater to the same population, but also it is few blocks away from our Parliament Hill, being a capital city of Canada. So that place, we started doing projects, and the first project was Proud Project, where we just wanted to understand the details of the demographics of the population. And the project was conducted in the same fashion, in the participatory fashion, meaningfully engaging everybody. And in that space, the same space, we enrolled 856 participants. It was a cross-sectional study, and we learned detailed socio-demographic information on their legal encounters and the experience of homelessness and the breadth of drug use, etc. And that gave us tremendous knowledge about a lot of these things, but most importantly, what it also shine light on, the tobacco prevalence. And mind you, the inclusion criteria for proud was not including like if you smoke tobacco. It was all comers from that population, homeless or at risk for homelessness or multi-drug users. And then when we analyzed the data, that's when we found out about 96% of the people smoke, which is, to put in juxtaposition of our capital city, Ottawa, about 9 to 12% of the general population smoke. And this is lowest in the whole of the province of Ontario, because we are the hillgoers, the parliamentarians, the sophisticated bunch, right? So the 96 versus 9% was a real eye opener for the people we work with. And because, it is just not the number, it's that much amount of disproportionate diseases and premature mortality and healthcare burden uh, of this population and for them. And that's why we decided to address the tobacco inequity through our PROMPT project, the participatory research in Ottawa management and point of care for tobacco dependence. So we took tobacco head on because now we had the buy-in from the community. The community saw the 9% versus 96%, how devastating it is, but also they were feeling the impact of it. And I will demonstrate it through the slides how it was. Now, as I know, I am preaching to the converted, and tobacco is the most devastating risk factor for most number of deaths and disabilities. Doesn't matter you are in Canada or in US. The cost of acute care hospitalization, prescription drugs, ambulatory care visits, on and on. The direct healthcare burden because of tobacco is disproportionately high as compared to other drugs or alcohol or combined. If you think about the indigenous population, and in your case, in US, indigenous and African American population, the proportion of people who smoke tobacco is disproportionately high, no matter where you look. This is a Canadian map. And the prevalence of current smoking, again, is very, very high, as we know, in the mental health issue patients. So thus, the tobacco smoking is devastatingly high in people who are poor, affected by mental health, racialized minority, LGBTQ, youths, on and on. We know that all. The dollar value because of the tobacco use is very, very staggeringly high. And this is all preventable cost. The society pays heavily behind each cigarette pack for this direct and indirect cost because of loss of productivity and premature mortality. Now, you also know this figure. This is from the 50th anniversary of Surgeon General's report, published in January 2014. And if some of you don't know, please look at this report. It's a 250-page document, but at least these two figures that I am going to show, you should use in your education and patient engagement. This figure shows how many diseases are causally linked to tobacco. Now, you must know in the world of epidemiology, cause and link is the most difficult thing to prove. And these many diseases are causally linked to tobacco smoke. And those in red are the ones added after the last report was published couple of years before this. So you can see, not just the cancers and heart disease and stroke, but diabetes, ectopic pregnancy, rheumatoid arthritis, immune functions, tuberculosis, on and on, the list goes on. Similarly, the health consequences of secondhand smoke, and again, these diseases are causally linked to tobacco use. So this is far-reaching problem, as we all know. And the tobacco company know it well how to do it. They did this with the cigarette by showing doctors' figures. They did this by using cute babies, the uh, celebrities, and now they are doing the same thing with the new tobacco products. As you can see, the similar advertising with the electronic cigarette and how vaping is cool and it is good. Now this is a dentist is using this, and the new and improved product of juuling. And we know tobacco companies have gotten this down pat. So this prompt project, what we decided to do was try and understand the optimal ways how to deliver the tobacco management in the hardest to reach inner city population, and how to do this in the community based kind of a organization. So at the bridge, we conducted this project, and these were the components of the project. So remember these components, okay? Because when I show you the results, I will, remind you of this. And only what we did, was what funding we had, and we did this project in a minuscule funding. We had a Canadian mental health nurse coming in there twice a week who was giving free and off-label nicotine replacement therapy to everybody, and some nurse counseling. But we also led some and conducted some peer-led weekly workshops, and those life skills workshops were whatever they wanted. They wanted to do a cooking workshop, financial literacy, banking, HIV, Hep C, mindfulness meditation, and they led the community knowledge forum quarterly, and everything was conducted by them, and I would show you how. We have described this model of patient engagement and how we engage this population throughout the process, right from the conception, design to implementation and knowledge mobilization. And it is described in this paper. We called this Ottawa Citizen Engagement and Action Model. And this is an open access paper, so you can download, read it. And when we were writing this paper, the vision was somebody in Timbuktu reading this paper should be able to understand what we are trying to do here, how we are engaging population, but adapt this model to their population and to their problem. So this is a very fluid model. So this is what we call true partnership, the citizen engagement, peer engagement, or patient engagement, whatever you may want to call in your lingo. So formulating the research question, as I said, we had the buy-in in formulating the question because we had done the previous study and dissemination of those results. So building the community-based participatory project, you do need their trust. And they on side of you, and the question coming from them, the relevance of the question coming from them. The second is designing the project. Now, how to design and how to implement that project. Now, I always said that I got so much wiser and better, and our project got so much better because people were by our side, people from the same community where the project was implemented with them, for them. And the successful implementation of the project was just because they were with us, and their voices were not just heard, but they were in the driver's seat implementing those strategies that they had brought to the table. Designing the questionnaire. And again, we might know a lot of questionnaires in our research field that we always use, and these are validated questionnaires, well used, well oiled machine. You're using it for decades. One such question I read at a table in a meeting when we had people from the community, we call them community peer researchers, and we were going over the questionnaires that what we could be including in our study. And I read the question, do you feel short of breath walking on the level ground? And you know what? They started laughing at me. And I said, why are you laughing? And they said, level ground means level headed. It means something else on the street lingo. That means you're not under drug effect. And we all started laughing. So we had to alter this well validated question from which has been used for decades by all the respirologists and pulmonologists all across the globe in the European studies and everywhere. And we had to change some wording, put something in parentheses, make sure the language is understood, make sure the content is culturally sensitive. But we only could do that because they were by our side, they were working with us. Now, recruitment. Now, me or my research coordinator, who is one person full-time job at the research center, the Bridge, don't know how, where, and these people engage and mobilize and walk around. But because the community peer researchers were with us, they knew exactly which social networks to explore, how to go there, how to engage this population, and how to get them to the center. So because they were by our side, we could enroll the genuine members of the target population within a matter of 6 months. Now, consenting. You must know, I don't know, English is my third language, and I don't understand a lot of things in that consent, in that legal lingo, but the ethics board wants that lingo. But our community peer researchers took the onus on them, trying to understand this language in that consent, made cheat sheets, notes for them, made sure they are saying the same thing what they have understood to their own peers. So they took a lot of onus on themselves and accountability, because they said, if I don't understand, how the hell I'm going to make it understood to the next person who is like me? And they made the extra effort to understand the consent, and they then administered the consent. Each participant was given $20 at the enrollment, like any other cohort study, for their time and effort. But a lot of participants thought they were just coming for that $20. But wait till I show you the results. Even the community peer researchers thought, oh, this person is just coming for $20. I will break my monotony of the steps of the project, the 10 steps, and share you some results. The population I was telling you was genuine member of the target population. Most of them smoked more than 20 cigarettes. Most of them smoked for more than 25 years. And over three-quarters of them smoked a lot of other illicit drugs such as crack, cocaine, marijuana, heroin, opioids, fentanyl, etc. Lot of them with mental health issues. These are self-reported mental health issues, but we also have similar numbers on anxiety and depression that we measured ourselves. But what I want to gather your attention to is this table, and see the food insecurity was about 80% of the people. So this population is truly marginalized and stricken with extreme poverty that you and I cannot even fathom with. So 80% of our population said yes to some or the other question of food insecurity. About 21% of them were indigenous, of the First Nations, Native people. And in Canada, about 4% of people are of indigenous origin. But when you come to the inner city, kind of the target population that we are targeting at the Bridge, about quarter of them are indigenous. This is a very sad commentary of Canada. I am sure similar picture exists if we look at San Francisco downtown or Chicago, etc. There is so much mental health issues. Now, we measured their spirometry, lung function test, and found that COPD was almost about 54%. This is a devastating figure. As you know, COPD is prevalent in about 10 to 15% of the general population, doesn't matter which survey you look at in Canada or US. And this disproportionate amount of disease is devastating. Same is asthma. In the general population, asthma, even considering obesity, is about 8%. But in our population, spirometry measured pre and post bronchodilation demonstrated about 17% had reversibility on their spirometry. And now you might say your spirometry was conducted by your community peer researchers. What they know, they are not healthcare literate. But you might say that is just a number measured by them. But when you look at the questionnaires, the disease burden measured by the questionnaire, the cough and phlegm, which makes the definition of chronic bronchitis, about 2/3 of them had it. What about wheezing and shortness of breath? Similarly, a lot of them having these symptoms on day to day, cough, shortness of breath, wheezing, etc. So their quality of life was quite affected. We measured their quality of life with the disease specific quality of life, the CAT questionnaire that I did not pay attention to on this slide, but it was very severely affected. This is a severe score of the disease specific. And the generic quality of life was measured by EQ5D, the well validated questionnaire, and those scores were also very comparable to any other population affected by COPD, even in terms of the severity of the COPD. So their quality of life is hugely burdened because of this disproportionate amount of smoking and the diseases related to the smoking. What about administering the questionnaires? As I told you, all our community research peers did this administration. And it was such an eye-opening experience because the questionnaires which were administered by them, they were doing this in a chit-chat fashion, in a very non-informal fashion. We were entering the data on an iPad and all the community peer researchers were doing it. Once there was a lot of follow-up, people were coming, and one of my community office's research coordinators said, oh, they are very busy, I will step in. And when Tina stepped in, they noticed that, oh, the drug use is low than when we asked them, so no more Tina. They noticed that themselves in real time. And then onwards, this was right in the beginning of the study. Because of the social desirability bias, we can imagine the drug use could be low if my research staff is asking questions. And since then, they took the onus on themselves, came extra time, created extra shifts, but they completed the follow-up and not my research coordinator. I said they did the spirometry and oscillometry. And some of you might know what spirometry is and how finicky the test is and how difficult it is to get the best results. But these people, during the training sessions, really took the time to learn it and master the technique and made sure they get certified in doing the handheld spirometry. And we had a lot of fun doing that. You might find some Facebook pictures of us displaying their certification of handheld spirometry. Follow-ups. I told you the story about the follow-up of the drug use, but we noticed that, the social engagement by the same people was very, very important. And that's how the follow-up could happen because of the social network of our community peer researchers. The follow-up rate was quite impressive. We gave $25 to each of the participants for their time and effort to conducting the study. Now, the most importantly, when we analyzed our data, we saw that majority of the people not just reduced their tobacco use, but subjectively they told us this, but objectively also we saw the carbon monoxide level was going down, as you see in this graph, the green graph. So it was not just the subjective reporting of reduction in the tobacco use, but also objective measurement that majority of them had significant reduction. Most important finding and very surprising finding that not just the tobacco use was reduced, as you see in this graph, but all other drug use. And this is the slide which led me to take the 6-month sabbatical, forfeiting my clinical income and focusing on just bringing the awareness of this project to anybody who like to talk to me, a businessman, a person walking on the street, or a politician. I just went and talked to so many people last year during the 6 months. But as you can see, we did not have funding or resources at the bridge to support people beyond what we did. We just provided them the NRT, the patch and the gum and some nurse counseling. We provided them a safe space to hang around and a very non-judgmental, low threshold kind of environment. Beyond that, we had no funding for, but you see these results. Almost everybody said they feel better, they eat better, they breathe better. About a third of them improved their general socioeconomic by getting a better place to live, by getting a better job, reuniting with their family. Some got a pet, some enrolled in school, some enrolled in drug rehab, and all of this by themselves. So all these things, the reduction in drug use, improving their general socioeconomic, they did it by themselves We did not have any expertise or funding to support them on that. However, this is not a black magic. The neurobiology of tobacco suggests us this. Neurobiology of tobacco is so devastating. Most commonly, that is the first addiction that they started at the age of 8 or 9 or even sometimes earlier than that. And structural changes in your brain because of tobacco addiction are very severe. It changes the configuration of the alpha 4 beta 2 receptors, and the neural receptors are modified structurally since that age. So the tobacco addiction is very strong and calcitrant addiction. So there are other three things you need to remember about tobacco addiction, that they are true about general population, but also true against all the stigma and stereotype for this population, also the most marginalized that we are dealing with here. The three things are: those who smoke, majority of them want to quit. They have tried quitting and they have failed quitting. So these three things are true with this population also. The literature shows us that. So when you think of these two things, the neurobiology of tobacco addiction, plus people who are suffering from this and want to quit, tried quitting and failed, when they got this kind of a atmosphere at the bridge where they were welcome, they were not judged, it was safe to come there, they saw the results themselves and their confidence got up, their self-efficacy improved, and they started making all other changes that surprise not just us, not just our community peer researchers, but themselves. It's the same people who thought they were just coming for $20, they made this change. Those people, our community peer researchers, thought this person is only coming to collect the $25 at the follow-up. They made this change and surprise everybody. Our follow-up rate was around 44-45%, but mind you, this is still quite impressive, because when you think of a tobacco cessation related studies, even in the general population, the follow-up rates are dismal as compared to any other study on hypertension or diabetes or whatever that may be. And when you think of this most marginalized population who has so many day-to-day challenges, such as the food insecurity I mentioned, you know, that population, if we engage this much, I think it is quite encouraging and empowering and very, very gratifying for us, but also for our community peer researchers. And there were some losses to follow up. There were some good reasons to losses to follow up, that they found a job and they called us and we have no time for you. Some found a better place. Some moved out to go to their family, reunited with their family. Some enrolled in school, as I said. 4 of our youngest participants enrolled in drug rehab. However, some also went the other way. Many of the people went to prison, and we don't know the number because our data sets are not connected. We can't get their data, but this is through the social network of our community peers. And I don't know how it is in your city where you live, but in my city, it's a capital city. My city needs to look clean on July 1st. That's the Canada's birthday, like the July 4th for you guys in US. And they call it a city sweep. The police goes around, and if you look wrong, if you're standing on the wrong side of the street, you just get picked up and put in the prison, because my city needs to look clean on July 1st. So this is how we treat mental health issues in this part of the world, right? So how many people went to jail, we don't know. Some got, of course, hospitalized, etc. Some just lost to follow up just for whatever reason. But our follow-up rate was still quite impressive. We learned lots of other things. The qualitative part of the study was quite empowering. And people told us that they want to be busy. They don't want to be bored. They want to come here. They want to do more. They want to participate. They want to give back. They want to volunteer. But you can imagine, once you're picked up by a cop for no fault of yours, but now you got a stamp. Once you know you have used drugs, or once you're homeless, with these kind of titles, you are stamped for life. Forget about like a job opportunity. You wouldn't even get a volunteering opportunity. And I have seen this, and I'm not ashamed to say this, that I see more giving and helping personalities in my downtown at the bridge rather than in my ivory tower. People are always there to help, and they want to do more, and they want to participate, and they are not given those opportunities. What about the data entry? Coming back to our model, we learned so much doing this with them. For example, there was a data entered. Some people wrote crack cocaine in grams, and some people said crack cocaine use in dollar figure. Now, me or my research administrator there didn't know what the going rate of crack was. Because these people were by our side, we could make use of that data. We could harmonize the data. And they, of course, learned a lot, and they were very thankful that we gave them this opportunity. But our data got so much more richer, and our project got better because they were by our side. Similarly, for the analysis and interpretation, because they are the end users, the results and outcomes are relevant to them. So having them by our side was very, very powerful. I said we did quarterly community knowledge forums, and they were ran, organized, and orchestrated by them. I would sit at the back bench, and a lot of people attended those from the neighborhood community. And once one Ottawa public health nurse was in the audience. This was in the beginning of our project. And she said, I always feel conflicted. When should I ask about tobacco when I know they have so many other issues going on about the homelessness and housing and the drug use and the mental health? And I feel like, why should I bring tobacco? And one of the panelists, we call them expert panelists, who was at the panel at that time, he shot back sharply and he said, any time is good time. We are suffering and we need help. So please do not feel hesitant in asking about tobacco. Please take that opportunity anytime a client or person or patient is in front of you. So a lot of people learned a lot of things from them. It was constantly a two-way street of knowledge. This was a recent media report. You can see that video if you go online after our prompt paper describing these results were published, and because the results were so outrageously positive. This was our prompt paper publishing all the results that I'm summarizing here and more. This is again open access paper. You can download and feel free to circulate. I said some of the time it was covered by our local CBC TV channel, and they interviewed some of our folks. And as you can see here, person who was on the panel that time, he said, I would probably be drunk on the sidewalk if not for the bridge, which gives him the purpose in life. And we did a lot of other community building activities at that space. We still do. I'm talking in past tense, but we are still continuing the work. Our peers have been very creative and very dedicated, started some community organizations. With another community organization, Duel, we run a Friday morning breakfast kind of a event, which is open for everybody around, because other times the bridge is only running activities to the people who are engaged in the project, but we open it up for other activities for other people. These are our community building kind of events, but also it creates employment. Like we pay people whatever they work around the bridge or around the projects or related activities, some cooking or cleaning. Of course, all our community peers get $15 an hour for whatever work they do on the project. May it be a meeting related to project, may it be training related to it, a project, or just the project implementation like recruitment, consenting, survey administration, etc., etc. So they are participating each way. One of our respiratory therapist group organized a paint night for us, and there we were painting away one night, and was a fundraiser to support the bridge. What next? We learned so much from this project, and people told us they want to do more. They want to get participating in more activities. So we created this Healthy People initiative, and we did a small pilot on 20 people from the prompt and gave them what they wanted: a volunteering opportunity, employment opportunity, schooling opportunity, proactively this time, in addition to giving them the tobacco patch and the gum and the nurse counseling and the safe space to hang around like we did in prompt project. And what we saw at the end of 6 months, that 15 out of the 20 people were successfully connected to what they wanted to connect it. And on the basis of this, now we are building up, and we got two grand new CIHR funding, and the CIHR is our parallel to your NIH in US, and we got two funding to do randomized controlled trials. We are doing in the same model that I just described here in Toronto, here in Ottawa and Toronto. One will be using e-cigarette, then other one is exactly like what I just said about the Healthy People Initiative. We would be doing that same exact thing in a randomized fashion. And we are building more partnership. People in San Francisco likes our model, in Philadelphia, Chicago. I was in Omaha a couple of months ago. And now I hope you guys come on board and we can do more together. I really believe in working together. And this is exactly what we mean by patient engagement, and not a tokenistic patient engagement where we bring in people in the strategic meeting and then we do everything because we are the experts. And here we have all the experts from the community working shoulder to shoulder with us. We did a lot of other events. This is a picture from our turkey dinner, but this is what is by the community, for and with the community. Because, I'm Indian. I don't know how to cook turkey. They know, and they did it all. And we just enjoyed every bit of the project. And this project would not have been possible if people around me would not have believed in my wacky ideas and supported me throughout, morally, administratively, and otherwise. And we got funding from the local LIN for the project that I just uh, described, and also from my division and department. And of course, thank you to all the bridge participants and peers. Without them, we would not have been able to achieve this. So we keep doing these kind of community events. We had an open house last September, and we would do another one. People from all over visited our center to see what we do. And there some couple of the peers are presenting stuff, and I am by the side telling. One of them was doing her high school, and she was shy in sharing that, and I told them this is what they do. And we had the run for a reason, the local Ottawa race weekend, where we had a team, and our captain is from the bridge, Ted Bignell, who is one of the person, and we do such events to keep the people engaged. Thanks a lot, and thank you again for inviting me, and let's see if we have any questions.
Thanks so much, Dr. Pakhalé, and congratulations on what are really fantastic results, and I'm sure was a lot of hard work that you put into the project. At this time, anyone who would like to ask a question, feel free to enter it into the chat box. I'll start off with one. So here in Minnesota, sometimes there's a bit of resistance among mental health and substance use providers to prioritize tobacco treatment. Do you see that in your practice at all? And do you have any advice on dealing with that issue?
Thanks a lot, Grace, for bringing that up. And this is not a problem or issue. This is a norm, actually. Most of the drug rehab centers or the treatment centers or mental health only deal with that issue and not tobacco. Oh, let them smoke. Oh, he has a schizophrenia. Oh, let her smoke. Oh, she's homeless. Oh, let her smoke. She's HIV. And this is being the norm. You know that even in mental health facilities, they distributed cigarettes. In shelters, they distribute cigarettes. You just have to come to the front desk. It was the norm up until recently in all our shelters. So this is a very uphill battle for all of us who believe in this. But the neurobiology of tobacco is so strong, and that's what we have to keep educating people that look, if you do this, rest everything will fall in place. Even their mental health issues get better because there is a lot of evidence now in the youth that tobacco might be causing even anxiety and depression, and a lot of other mental health issues might be getting exacerbated. Some people, what they said when they got reduced their cigarettes to such a low extent, they said, as though the fog in my head was clear, I can think clearly now. And so we have to keep doing this one person at a time, but it is an uphill battle. as you said.
Of course, yeah, and it's so great that you have those messages from your participants themselves, because I think that's really the most powerful, to hear from them how much it impacts once they reduce their tobacco use. So another question, did you find when you were doing the study that participants in the research spread awareness about tobacco cessation with the broader community as a result of their participation?
You mean broader community, like other than those who were in the project?
Exactly.
Yeah, I mean, it is difficult to know, right? As a purist, I mean, we measured what in the people that were engaged in our project. So, but we heard the anecdotes, like people are now, because what happened was we finished our funding and we were not actively recruiting. And even after we finished the recruitment for the earlier project and we were completing the follow-up, we still keep getting knocks at the door. So the word was out and this project was helping people. So people are interested. That much I can tell you. Have they started reducing? I don't know, but more and more people got interested and knocking at our door, and they are ready to jump into the next project that we hopefully soon start recruiting. The interest definitely has gotten up.
Great. Another question, did you expect to see the concurrent substance use decrease, or was that a surprise for you in looking at the results?
I mean, to tell you the truth, when knowing the science behind it, the neurobiology of tobacco and how it affects, and there is very, minuscule evidence in the study, but the neurobiology is so strong that I was hoping that we see that. I wasn't sure we would see that because we are dealing with the very hardest to hard reach population and lot of people using lot of substances for a lot of years, right? So I wasn't sure we would see that. So definitely that was a surprise, a pleasant surprise at that.
Great. What other health issues could this model be used to address?
A very good question. And that's exactly what I think our funding agency saw in us, in our model, because you can think of maybe obesity or diabetes or COPD management. And if you can do this in this fashion, in the community, with the people from that community who is suffering from diabetes or obesity or whatever that may be, or mental health issues, it will be adaptable to any of the chronic illness, I would say. And if you do it in the fashion with the people, you will see the downstream effects on other things. Because, anybody's last name is not diabetes or high blood pressure. There are so many other things going on. And if you see things falling in line, all other things fall in line, like we saw. So their blood pressure is better and physical exercise is better. Like people started walking better in our cohort, because they say, now I don't feel short of breath as much as before. I can run to my bus. So any chronic disease, and I would say any population, even if it is a remote community, if you engage people from that community and put them in the driver's seat, give them the tools, and you be their quarterback, and they will run the project for the problem that is pressing for that community. So may it be a remote community or rural community or suburban community. It could be an issue which is important for them, pressing for them, and then you are just giving the tools in their hand to tackle that.
That makes a lot of sense, and I think we don't have any other questions, but I think that's a fantastic note to end on. And thank you so much for sharing this project with us, and we really do hope that it inspires similar work and similar conversations here in Minnesota, because as we've said over and over, we're facing so many parallel problems, even though there's a border between us, but things are not so different down here. So thanks everyone for joining us today, and feel free to reach out to Dr. Pakhalé if you have any questions, or Annie here if you have any questions, and our websites are there, and we'll send out the recording and evaluations after the webinar. So thanks so much and have a great afternoon.
Thank you very, very kindly.